Kia ora tātou. Welcome again. I think this is the last lunchtime webinar of the year. I'm Pauline from Mobile Health, and it's my pleasure today to introduce to you Alesha Smith, who's the Associate Professor at the University of Otago School of Pharmacy and also Director of Airmed. Alesha will speak about the development of Ako Hiringa, a new primary care clinical education program. She will also present He Ako Hiringa's interactive data tool, which is set for release early next year. And this is an interactive prescribing dashboard that allows prescribers to analyse and compare their medicine management behaviour. As a developer of the dashboard and a health researcher herself, Alesha will then demonstrate how the dashboard can be used to explore the care provided to patients using medicines for type 2 diabetes as an example. Welcome, Alesha.
Kia ora koutou. Thank you, Pauline, for that lovely introduction, and thank you everyone for joining. I know it's getting a little bit towards the crazy end of the year, so I'm delighted that we've had lots of people join today to hear about He Ako Hiringa and the EPiC dashboards. All right, so I thought I'd just briefly outline what I'm going to talk about today. So firstly, a little bit of an introduction about what He Ako Hiringa is. So who we are and what we do. And then, as Pauline said, I'm going to introduce the EPiC dashboard and tell you a little bit about that and where the data comes from that feeds into the dashboard, and also give you a live demonstration. And just to let you know, these will be recorded, this part of the session, and they'll be popped up on our website as well for future reference. The Q&A session won't be put on the website, so feel free to ask any questions as you go along, and I can then hopefully answer those towards the end. Okay, all right, so who is He Ako Hiringa? So He Ako Hiringa is a trading name for a joint venture between Airmed, which is my company here, and we're a data science and health research company based in Dunedin. And we teamed up with the health media. So many of you will already be aware of the health media. So they publish things such as the New Zealand Doctor, Pharmacy Today, the Healthcare Handbook, the Everybody Sheets, and also do lots of e-learning across a range of health disciplines. So we've teamed up together, and the health media are in charge of all the educational content, so developing a lot of the information that you'll see on our website, and we're Airmed responsible for the data and the dashboard. So much of our work is around using the data as a core part of this program to really help direct and develop the educational content that comes out. So here's all our lovely team down the bottom here. So we've got lots of folk right across the country, from Northland down here to Dunedin, working on this project. Right, so we are supported by an expert advisory group. So this is a pharmac expert advisory group, and that's just been formed recently. So we have 10 key individuals across the health sector who have a really strong understanding of medicines access equity in our priority population. So that's a mix of GPs, pharmacists, and nurse prescribers. And they've been nominated by their various organisations, or their names put forward to come onto our panel. And they're there to help us give some expert advice, review our recommendations, agree on direction, and help us set priorities moving forward. So they're a really key support network for He Ako Hiringa, and we're delighted to have the group that we've got on board. We also have an equity advisor, which is Associate Professor Sue Kringle. So she's from the University of Otago, the Otago Research Unit at the School of Medicine at Otago, and she's been really integral in helping us with our equity work and linking us up to all the fantastic people across New Zealand who are inputting and providing guidance and advice around that. All right, so what is He Ako Hiringa? So where did we kind of appear from, and why have we become all of a sudden into this sector? So we tendered and were awarded a pharmac contract this year, and it's around the responsible use of medicines. So for many years, pharmacs had independent organisation deliver educational content around the responsible use of medicine. So this is around making sure medicines aren't overused, underused or misused, and trying to get the optimal use of medicines for everyone in New Zealand. So this is a 4-year contract that we'll be undertaking, and we started in July this year. So we're just getting into it and getting all our things set up. And this is really, the launch has been only in the last few weeks, all our resources have come about. So the reason why we have a strong medicines access equity focus is that we know that not all New Zealanders are achieving the best health outcomes from medicines that are funded by PharmAC. So this is due to a range of barriers that I'm sure many of you are aware of and have heard lots about this. So we know that in particular, Māori population are not benefiting as much, and also, although not as extensively studied, it would appear that Pacific peoples are also facing very similar barriers as well. So a scope of our work for the He Ako Hiringa project is that our primary intervention focus is on primary care clinicians, so not patients. So we won't be developing any consumer or patient information, and we're not mainly working with hospital prescribers or healthcare professionals. It's for primary care clinicians. So that includes GPs, pharmacists, nurses, anyone working in that primary care space, particularly around medicines access equity. So our priority populations are the same target or priority populations that PharmAC have as well. So that's Māori, Pacific peoples, those living in rural locations, people from former refugee backgrounds, and those living in high socioeconomic deprivation. So it's really thinking about how we can help reduce inequities for these populations moving forward. So why is it we're so concerned with these populations, and what are those inequities that are occurring? Well, there's lots of gaps in medicines use with these groups of our population. So for example, this was some work commissioned by PharmAC and was published in 2018. And when they looked at the medicines use across the board, once adjusted for the burden of disease, there was actually about 1 million fewer scripts being dispensed by our Māori population compared to non-Māori, which means that we're then missing lots of opportunities to improve their health. So we know that lots of long-term medicines provide beneficial outcomes, and if they're getting 1 million fewer scripts compared to everyone else, then they can't achieve that same benefit. Also, this was updated research from 2013. So when compared to 2013, the 2018 data showed that the inequities had actually increased. So that gap was getting slightly bigger. So the access has become worse over time. And although there was some good news that there was some improvement in the persistence of medicine. So this means that people are actually regularly picking up their medicines. So if they have been prescribed it, we're seeing them continue to take those over the long term, which was great. So this is again looking at some of these gaps. So the graph that's being shown here is looking at the difference in script counts between Māori and non-Māori. So this is access in the little stripy bars here and persistence in this bar. So anything below 0 here shows that there's a gap. So they're not receiving as many medicines in this area compared to non-Māori, and anything above the 0 line is showing that they actually have higher access or higher use of those medicines. So you can see that the largest shortfall here is actually with cardiovascular medicine. So there was 300,000 less prescriptions in cardiovascular medicines alone for Māori compared to non-Māori, even when adjusted for burden of disease and age standardised. So this was around particularly beta blockers, statins and ACE inhibitors. So primary prevention and medicines were not being provided to this population. Up here we have asthma coming in quite high, and also diabetes here. Whereas over here, we can see that the largest excess of medicines was actually in the osteoarthritis medicines, which includes NSAIDs. So this would seem as if it was inappropriately high, and that may be a lot of NSAID prescribing for gout instead of the long-term preventative medications being received. So it's a pretty sort of stark contrast when you can see we've got a lot of medicine groups here sitting below the bar and below 0. So not surprisingly, our scope of work within those priority populations is around diabetes, asthma, cardiovascular diseases, and gout. So these are the focus conditions, and that's the content and education and dashboards coming out of He Ako Hiringa will be solely focused around these conditions. And the reason why those conditions have been chosen is because you've just probably seen on the last graph that this has got the highest unmet need or the most potentially inappropriate prescribing within these conditions. And they're also conditions most amenable to medicine. So we can make a real difference if people can get that same access to the medicines as others. So you can see here that some of the inequities with these conditions, again, if we look at the hospital admission rates for asthma in children, that 11.8 out of 1,000 Pacific children were admitted to hospital, 8.1 out of 1,000 Māori children, whereas it was only 4.3 out of 1,000 European or other children. So you can see there's big differences occurring here. Same with the prevalence of gout, so it's much higher in our Māori and Pacific population compared to non-Māori populations. However, they're much less likely to receive that preventative urate lowering therapy compared to European or other populations. So what does medicines access equity mean? So you've already heard me mention several times that we'll be focusing on medicines access equity. So access really means that firstly the drugs or medicines are available, they've been determined to be safe by a regulatory body and funded, so that's all our medicines on the schedule. So we have Pharmac have funded many medicines that are sitting within the schedule, so we have the availability. We also want people to be using them optimally, so getting the best benefits they can from the medicines, which will then provide great outcomes or better outcomes than if they didn't have those medicines. So there's lots of drivers and reasons why we don't achieve that medicines access equity. So you've seen there's already quite a large gap between different populations within New Zealand. So some of those drivers are these ones, and we refer to these as the 5 A's because obviously they all start with A. And there's lots that we as health professionals and educators can actually look to improve on within primary care. So firstly, we've got availability, so that's Pharmac's decisions around funding and who can access the medicines. We've got affordability, so making sure there's no cost barriers and that people are able to access prescribers and medicines at an affordable rate. The accessibility, so there's no challenges of being able to see a prescriber or get to the pharmacy. The acceptability of medicine, so making sure that patients are really informed about their medicine. There's been shared care and a patient-centric focus on care when prescribing medicines. So we know that the more that people are informed and accepting of the medicines, the more likely they are to be adherent and persist with their treatments. So it's a really key area for us, and also making sure there's appropriateness. So really the equality of prescribing as we'd expect, that the medicines being prescribed are following guidelines, and that we're ensuring outcomes for everyone across the board. So we don't want to see sort of lots of different variations in prescribing within different regions or different populations. We want to see everyone getting the same access and treatment. So the He Ako Hiringa approach is that we're kind of undertaking it's a three-prong approach, I guess. So firstly, we'll be developing education and awareness raising resources. So these are all free and available on our website, which is down here. So the education content will be focusing on those conditions and looking at how we can help reduce inequities across the priority populations. We'll also be developing what's traditionally called prescribing reports, and this is via our EPiC dashboard, which I'm going to show you soon. And another really key part of He Ako Hiringa is that we really want to engage and collaborate with the primary care sector. So I'm sure lots of you out there have probably already heard from us or from Anna, our engagement lead for He Ako Hiringa. And why we want to do that is because we want to work with the sector in helping sort of promote and make the most of the work that's already being done in primary care. So there's lots of good programs and resources being developed already, and we don't want to duplicate that work. We want to complement that work, promote that work, and bring it all into a cohesive educational resource for people moving forward. So if you haven't heard from us and you've got some great things that you would like us to know about, then please get in touch. We're very much wanting to reach out to all people in these target areas and conditions. So, for example, we've already got some medicines access equity video up on our website. So this is a fantastic resource which is really talking more in depth around what medicines access equity is. And it's also got some fantastic tips from some people that you may know in the health sector, so pharmacists, nurses and GPs working across primary care. So it's definitely worth a watch. It takes around about 20 minutes, so I can highly recommend that if you'd like to know more about medicines access equity. All right, so onto our EPiC dashboard. So this is the bit that I'm the data lead for and working on. We've been busy with this for the last 6 months, getting it ready for launch. And it's what it is around a dashboard or a platform within the web that allows primary care clinicians to explore prescribing trends for their patients and also their practice patients. And we also have benchmarked that prescribing to other prescribers and practices most similar to you as a prescriber or the practice as a whole, and also allowing comparison to national averages. So what we hope by doing is that if you can benchmark to someone most like you, so in that regards we mean someone, so if you're a primary care, a practice, then we'll match the 10 practices most similar to you in demographics. So that's ethnicity or your patient population's ethnicity, age, size of the practice, gender as well. So you'll be matched with the 10 practices most like you in that regard. So you can see how you differ and whether your prescribing varies compared to those other practice populations. And it's quite interactive, the dashboard, so it allows you to filter by different demographic features such as ethnicity or age group or gender. And the hope of this is that you can reflect on the prescribing or your practice's prescribing and think about what it is you may want to investigate further if there is differences between you and the practice other populations. So what data is being put into these dashboards? So currently we're using the Ministry of Health National Collections, and many of you will be aware of the data that's obtained in these. So these are mainly administrative collections. So we have at He Ako Hiringa, or Airmed, where I work, we get regular feeds from the ministry around all these different data sets. So we know, we can see when patients have been to hospital, when they've had medicines dispensed, what practice they're enrolled at. And it's really important also to note here that this is all de-identified, so it's encrypted NHI. So although we're linking by NHI that is encrypted, so we can't identify individual patients, but we can track them using the encrypted NHI across the health system. So we know, for example, when someone's had an immunisation or been to ED or also had a baby. So that allows us to get a really good understanding of medicines use, and then also effects such as a visit to ED for an adverse effect or a hospitalisation for a complication of a disease. So this data is being fed into the dashboard on a regular basis, and we will be looking to expand our data sets over the next 4 years. So we're chatting with PHOs at the moment around some of their diabetes data that they have. We'll also be investigating with the Ministry of Health around the e-prescribing data so that we can look at when medicines are just prescribed versus dispensed. And we're also really keen to talk with other vendors who have data in primary care that we can potentially use to populate our dashboards and make them the most useful and relevant that they can be. So very much the data in there at the moment, and the dashboard is our baseline data sets that we've got. All right, so now I'm going to give you a little bit of a sort of show and tell of the dashboard. Now I'm just going to try and jump out of my presentation for a moment and take you into the dashboard. All right, so this is our dashboard here. So it's currently in beta testing.
We can't see it, Alesha. We can still, we're just looking at your presentation, not on slideshow at the moment.
Okay, let me see if I can swap new share. Okay.
You might have to stop sharing that one before you start sharing them.
And I'll start sharing onto this one. Okay, is that now showing?
That looks like it.
That looks like it? All right, great. Okay, so this is our dashboard, which, as I said, is in beta testing at the moment, and we're always looking for more beta testers. So if you want to be a beta tester, please get in touch with us, and I'll give you some details on that soon. So the first dashboard, the first sort of cab off the rank, so to speak, is our the diabetes dashboard, and this is really trying to get clinicians to turn their attention to the diabetes population. So thinking about who your diabetes population is, what medicines are being prescribed for people with diabetes, and also looking at some of the step treatment. So what we've got here, first up, is this is logged in, and this is just a random practice that we're seeing across that's been populated in here. So this is an individual prescribers data here. So we've got your patients. Then we can swap to your practice, which is now showing, so each clinician can choose to nominate a primary practice that they would like for their dashboard to display. So this is this prescriber's practice, and then we can also see the national data. So this is all New Zealand data. So even if you're not a prescriber or don't have data, you can still come on to the He Ako Hiringa dashboard, the EPiC dashboard, and look at the national data, so we can start getting a flavour for what's happening in diabetes across the country. So if we go back to the practice data here, you can see that this is looking at patients with diabetes. You can hover over to see how many people with diabetes there are. So this practice has 628 female patients with diabetes. And then we're saying we've got the age group breakdown, the ethnicity breakdown, and also the deprivation. So this is looking from least deprived to most deprived. If you want to compare this to all patients within that practice, so this is anyone without diabetes, you can do a comparison here, and you can see that blue is now the patients without diabetes versus the diabetes patients. So I think this one's quite evident here that this practice has a lot of their diabetes patients are living in the most deprived areas of quintile 5, and also have a lot of Pacific people with diabetes as well. So then within each of our data stories, we have some education based around each story, so some sort of key messages and tips for prescribers. And this, our EPiC tip will always be sitting up here. So these are equity focused to help turn your attention to how you can use or reflect on these dashboards and think about things from an equity perspective across your practice. So secondly is the current treatments tab. So this is looking, and apologies, it is a little slow just because we're working off of the webinar version here. So this is now looking at your practice here, and this is the current diabetes treatment for this practice. So it's very evident that metformin is the most commonly prescribed diabetes medicine, which is no surprise. We would expect to see that. But now what we have here is a comparison with the, we can compare with national data. So what this is looking at here is the national averages compared with this practice's prescribing. So on a whole, this practice prescribes less metformin than the national, so only a tiny bit, 0.9% less, whereas they prescribe a lot less vildagliptin, so 4.4% less vildagliptin prescriptions compared to the national average across all practices, whereas they prescribe a lot more sulfonylureas. So this is obviously, this practice favours that class of drug over vildagliptin or these ones here. So the good thing with this is now we can actually look by ethnicity, so we can start to see where those differences may be occurring and whether there's any sort of standout messages for particular practices. So you can see that really the only ones that are being prescribed more, so it looks like here that our, oh, sorry, I'm just going to move things out of my way on my screen. Our Māori patients in this practice here are receiving less sulfonylureas than everyone else. So that might be something that they'd want to think about or reflect on, or find out a little more information about why that might be occurring. Whereas you can see there's a lot more insulin being prescribed compared to the national average for Māori patients on this side. So we can filter also by other factors. So for example, this one's looking at deprivation. So you can see that the most deprived here is actually receiving less metformin than others. And again, over here, we're seeing less than the national average for those living in quintile 5. So only slightly, but it just starts to help raise awareness and think about, reflect on the prescribing that's occurring and why there might be differences. And it might be that those differences are actually valid and it's different patient populations, but it also might be a factor to consider why that's occurring and what else could be done to look into that. All right, and our last one here is looking at our stepped treatment. So this is looking at, we've got 1, 2, or 3 or more medicines being taken by the patient. So this is really looking at the escalation of treatment. So we know, for example, that that when treatment's escalated for younger ages, that's often more beneficial rather than staying on one medicine and not getting the same control of the diabetes as you may with other ones. So this is looking at the proportion of patients here who have had one medicine versus 2, 3, or then onto insulin. And when compared, you can see that the national average actually has more patients on just one medicine compared to this practice. So that might be a good thing that they've actually escalated treatments, or it may be that this practice has got more patients on two or more medicines, which may then actually, they might benefit from moving to insulin if that's the case. There. All right, now I'm going to stop sharing my screen and jump back into our PowerPoint. Okay, so hopefully it will come back. All right, can you see the PowerPoint again?
That's fine.
Fantastic. All right, so I guess that's really where our sort of introduction into our dashboard and how it's happening. And as I said, we really are looking for some dashboard beta testers. So if you're keen to be an early adopter and have a go, if you've got some prescribing data that you would like to investigate, then yeah, please get in touch with us. If you want more information about the dashboards and the data, and also a little bit of a demonstration or instructional videos, these are up on our website. So feel free to show colleagues or point colleagues in this direction to having a look at the videos if they want to sort of have the same demonstration that I've given you today. And likewise, this webinar will be going up on our He Ako Hiringa website as well. So there's more information available there, or of course, you're welcome to contact us. So I guess that ends the kind of formal part of the presentation that I was going to do, and I'd love to take some question and answers or hear your thoughts about the dashboard or any ideas for improvements, etc. So thank you.
Thanks, Alesha. There's no questions at the moment, but if we wait a few minutes, I think they might come through. That's fascinating, isn't it? Amazing. All that data.
Yeah, no, it's really exciting.
Dashboard. Wow. Yeah. I mean, you must have been looking at what data you've got already. What are the take-home messages that you've noticed already?
So definitely that within the step treatments, we've seen a lot of Pacifica patients on 3 or more medicines, which is much, much higher than any of our other patients. So that's definitely one area that we've noticed that's quite standout. The other area is that there seems to be quite a lot of variation in the newer medicines, so the vildagliptin medicines and the uptake of these across different sort of areas within New Zealand. So we're often seeing little pockets of some sort of prescribing and not others as well. So that's probably our sort of key messages at the moment. We will have more diabetes stories coming and launching in the new year as well, so that we'll start looking at other factors and sort of impacts of medicine across different populations as well.
So when you say the Pacific Island population have more medicines, are you thinking in the context of their diabetes, or are you thinking generally?
Yeah, just generally in terms of the diabetes medicine. So we wouldn't expect lots and lots of patients to be sitting on 3 or more medicines. We would think that we would want to start to see a shift towards insulin to get the diabetes under control. So the 3 or more medicines is indicating that it might not be under control, and that insulin might be beneficial for some of those patients. So we're seeing a lot more on that sort of treatment step rather than moving to insulin perhaps.
It's fascinating. And that kind of data set, I mean, it obviously from your point of view, it's about medicines at the moment, but there must be other areas of practice that could be really helpful to compare with similar practices. I'm thinking of screening processes and all sorts of things.
Yes. So as you introduced at the start, I also work at the university. So I do lots of health research. So yes, we use lots of these data sets for research. So we do lots of maternity-based research, polypharmacy-based research, also looking at hospital admissions and other things for certain conditions as well. So super useful data set. We're really lucky in New Zealand to have these data sets available. I know lots of other countries are very jealous of us that we have the ability to link up. So we are really keen, and we do work with other organisations around helping them understand their data and being able to use those data sets to answer, various questions for sure.
And how long ago did it start? Like, do you have a baseline? Because when
so
you start,
the data is really good. It started getting a lot better from about 2008 onwards. So we've got, well over 10 years of quite complete data for most of New Zealand, and we're capturing about 96% of all New Zealanders. So we're only missing about 4% of patients, which we know are not enrolled in a practice, so they're a little harder to find. So it is very strong data set.
Yeah. And obviously it bypasses all the different types of patient management systems that practices use, because it's an internet-based process rather than depending on medtech or any of the other patient management systems.
Yes, although we are keen to work with vendors, and we are sort of chatting with them now about how we can integrate our systems so that prescribers can get the most benefit out of the data. So there's different data held by those sort of practice management systems that would be really useful to team up with the bigger data sets, and help prescribers be able to find patients who might benefit from different treatment management.
Right. Well, there's still no questions coming in, so I'll just ask you, has it raised any questions that you can think you can repeat for other people's benefit as you've been talking to practices around the country? What are the sorts of questions that have been raised? Yeah,
so we've obviously done lots of engagement around this, and one of the questions we get asked a lot is, how can I find that patient? So you're saying, we've got these patients on medicines. How do I find them so I can move them? So we are working to be able to provide some audits for prescribers so that they can, we're going to help them be able to find those patients within their systems with the direction of hoping to align and be able to streamline that into a one-click kind of operation. But in the first instance, we'll be helping them do queries within their practice management system and building those in different systems as well. So that's definitely one question we get asked a lot. The other question we also get asked a lot is, why are we not doing mental health medicines or antibiotics? Because they're also two areas of quite big focus for the health sector. And as I sort of said back at the beginning, that those we've picked condition, well, we haven't, Pharmac have picked conditions, target conditions that are most amenable to medicines if the optimal treatments are available. So that's why, we've gone for the focused conditions that we have.
I do have a question now. So Vivian is asking, is pharmacy able to use this?
Oh, yes. So pharmacy dashboards are coming. So at the moment, we will be primarily prescribers. So that's GPs, nurse prescribers, and pharmacist prescribers. However, we are looking to build a pharmacy-based dashboard around dispensing data as well. So that should be coming towards the end of next year. But pharmacy at this stage can still log in and look at the national data, but then they'll be able to log in and look at the pharmacy-based dispensing as well.
So would that be useful for like community pharmacists, so you're thinking?
Yeah, so we're hoping that then that can help pharmacists think about how they can work with maybe their local GP around equity-based services, or help around information for patients, or also service development. So what other, you know, little clinics or services they could run from their pharmacy to help reduce those inequities or provide more optimal care for patients.
Yeah, oh, good, good. All right, well, there's no more questions, and I think it's probably time to bring it to a close. I mean, that's that. Unless you've got anything, have you got any other interesting tidbits that you think that people might find useful?
Yeah, I guess it's just a bit of a watch this space. So there are more things coming, and if I guess are in an organisation that would like to have or help do some of this work, or have more data available, then please get in touch. We are really open to collaborating to develop dashboards with different groups. So you know, nurse practitioners and practice nurses, as well as pharmacy and things. So we will be looking for people to engage with across the sector. So I think that's really my tip, is just keep coming back, keep looking. We will be developing new resources all the time, and yeah, thank you.
Very good. All right. Well, thank you everybody for joining in today. And thanks again, Alesha. That was really interesting. And yeah, go well in the lead up to Christmas. Hope it's not too fractious for any of you, and that you get a nice relaxing time when you get there. Thanks again.
Thank you.
Bye-bye.
Bye.